Hi, I'm Soumya Bhamidipati, a journalist at Health Central, here at tonight's Talk debate on the end-of-life choice bill. With me is ex-director of Waikato ICU and past president of the End-of-Life Choice Society, Dr. Jack Havill. Jack, thank you so much for being here with me tonight.
Thank you.
So with this bill, why is it important, and why is this an important issue right now?
Well, a lot of people die in very severe circumstances, pain and suffering, not just pain, but lots of other suffering as well. And they want to die in dignity, they want some autonomy, and they want to avoid indignity. They want to have the autonomy to do what they think is right, have choice. That's why our name is called End of Life Choice. And they don't want to die in extended circumstances, anaesthetised. They prefer to die while they're awake and saying goodbye to their relatives in a good way, and they can have spiritual things going on and have fun out there and as well, and so that's a general thing. Yeah, but fundamentally it's avoiding suffering and pain at the end of their life. Mm.
And what has influenced your stance or point of view on this?
Oh, well, in intensive care we quite frequently take off life support off people and cause their death. And that's very similar in some ways. But the thing is that in intensive care you give a lot of treatment, a lot of extended treatment, and you're always worried about producing somebody who doesn't want to live afterwards, or who's damaged, so damaged that it would be better if they weren't alive. Mm. And so that influenced me way back.
Yeah. So is there a difference between euthanasia and palliative sedation?
There are differences. Assisted dying, which we like to call it, is at the request of the patient. And it has two doctors assessing whether that's a legitimate. They've got to be competent. Now, palliative sedation is often a gradation from being not drugged to being heavily drugged, and then going on to being anaesthetised. And often they don't get proper consent because they talk to the family and they'll tell the patient what's going on, but the patient's too drugged up to give proper consent, and basically we describe it as slow euthanasia because the patient has the nasogastric, or they stop feeding them, and so they just give enough drug not to kill them, except that sometimes they do, and that's called a double effect. So there are differences, but there's similarities. Mm.
If the end-of-life choice bill did come into legislation, what would that mean for health professionals? What impact would that have?
I think health professionals, well, at the moment, there's more doctors theoretically against than for, but I think, as has happened in other legalised jurisdictions, that the doctors gradually come around and see it as a good thing. And for instance, in Belgium and in Netherlands, the trust in doctors is higher than just about anywhere else. It's 80%, 90%. So they learn to trust their doctors. They learn to, when you talk about assisted dying, when they're discussing that, the doctors start talking about it with them, which now they quite often avoid the subject. but there will be some that will help the patient die. Now, some people like to say, oh, the poor doctors, they'll have secondary effects and all that. But in fact, when you talk to the people who are doing it, they feel really honoured to be with the patient at the last stages of their life, and they can do a lot. It obviously affects people in different ways, but generally they sort of feel honoured to be at a very intimate time of the life of the patient.
Great, thank you so much, Jack.
That's all right.
Thank you.